Welcome to Navigating the Medical Revenue Cycle. My name is Stacy Olson, and I am a certified professional coder with a specialty credential in evaluation and management services through the American Academy of Professional Coders. CPT is the code set used to report professional medical services. This code set is developed, maintained, and copyrighted by the American Medical Association. Every attempt has been made to provide you with accurate and current information, but the coding rules can and do change, and it is always the provider's responsibility to know the state and federal rules and to remain current on payer policies. Today's information is not legal advice or a reflection of any individual health system's policies or procedures. It is not instructing providers in the services they may perform and/or bill, but is meant to inform you of general knowledge and best practices for billing medical services. Our objectives for today's session will be to recognize how contracting and credentialing affect the revenue cycle, identify steps for selecting practice management systems and electronic medical records, describe different insurance models, explain the revenue cycle, and identify successful strategies, and express the need for policies and other tools needed for optimizing your revenue cycle. First, let's talk about some general information that will apply to all aspects of the revenue cycle. The Health Insurance Portability and Accountability Act, or HIPAA, contains what is known as the Privacy Rule. It permits the transmission of important information while protecting the privacy of patients, but is designed to be flexible and comprehensive to cover a variety of uses and disclosures. It applies to covered entities such as health plans, healthcare clearinghouses, and healthcare providers. Every healthcare provider who electronically transmits health information in connection with certain transactions is expected to comply with the privacy rule. These transactions include claims, benefit and eligibility inquiries, referral or authorization requests, and any other transactions that have established standards under HIPAA. Using electronic technology such as email does not mean a healthcare provider is a covered entity. The transmission must be in connection with a standard transaction. The privacy rule covers a healthcare provider whether it electronically transmits these transactions directly or uses a billing service or other third party to do so on its behalf. Healthcare providers include hospitals, physicians, and other practitioners that furnish, bill, or receive payment for healthcare. The privacy rule also applies to business associates who are hired to perform certain functions on behalf of providers or another covered entity that involve the use or disclosure of individually identifiable health information. Business associate functions or activities on behalf of a covered entity can include claims processing, data analysis, utilization review, and billing. When a provider of healthcare services uses a contractor to perform services or activities, the rule requires that the covered entity include certain protections for the information in a business associate agreement contract. The covered entity must impose specified written safeguards on the protected health information used or disclosed by its business associates. A covered entity may not contractually authorize its business associate to use or disclose any protected health information that would violate the rule. A covered entity may not use or disclose protected health information except as the privacy rule permits or requires, or as the individual who is the subject of the information authorizes in writing. The Health Information Technology for Economic and Clinical Health Act, or HITECH, was enacted to promote and expand the adoption of health information technology. HITECH addresses the privacy and security concerns associated with the electronic transmission of health information through several provisions that strengthen civil and criminal enforcement of the HIPAA rule. It also proposes meaningful use of electronic health records throughout the United States healthcare system. Meaningful use utilizes certified electronic health record technology to improve quality, safety, and efficiency while reducing health disparities. It is meant to engage patients and their families regarding their health, improve care coordination, and public health while maintaining privacy and security of patient health information. The goal is to improve clinical and population health outcomes, increase transparency and efficiency, empower individuals regarding their health care, and provide more robust research data on health systems. CMS has agreed to pay incentives to organizations who make a concerted effort to implement and effectively use electronic health records and transmit data. While commercial payers may not participate in meaningful use, they are also interested in these same measures and are looking for ways to incentivize participating providers to engage in these same outcomes. Selecting electronic systems to manage medical records and the practice's revenue cycle are important steps to having a compliant and profitable practice. Opportunities for automation in medical practice have rapidly increased over the years. From eligibility verification to claim submission and patient billing, manual, time-consuming tasks can now be streamlined and simplified with practice automation. The right technology will ensure a smooth transition to new work processes. In the case of automating a practice's revenue cycle, the right practice management system is key for improved efficiency, electronic transactions, and workflows. Practice management systems can organize administrative and billing functions. They typically include features such as capturing patient demographics, appointment scheduling, patient pre-registration, including insurance eligibility and benefit checks, maintaining lists of insurance payers, performing billing tasks, and generating administrative reports. Choosing and purchasing an appropriate system, whether it's your first system or you are upgrading to a new product, can be overwhelming. Selecting software that does not integrate properly with your practice workflow or that does not contain the features your practice needs can result in unnecessary costs, wasted time, and a lot of frustration. In addition, purchasing a system that is not well supported by the vendor or is not compliant with federally mandated transactions and code sets will result in significant billing and collection challenges as well as administrative inefficiencies. Electronic medical records and electronic health records are not the same thing. It is important to identify which system is right for your practice. Electronic medical records are created to be accessed within a single medical practice or healthcare organization, while electronic health records are designed to be accessed by multiple entities. These systems replace traditional paper medical records with computerized documentation and store the patient's health information. They include the patient's demographics, progress notes, medications, and medical history, as well as the diagnostic test results from all healthcare encounters. There are many vendors to choose from that can provide a variety of applications and tools for collecting, managing, and sharing patient information electronically to assist in clinical decision-making. The features you will want to look for in your electronic record system are health information and data storage capabilities, results, order entry, and decision support management, electronic connectivity and communication, patient support, administrative processes, the reporting capabilities, and its ability to collect population health outcomes. It is also imperative that the system has HIPAA-compliant safeguard features. The system you select should improve patient safety, support delivery of effective patient care, facilitate management of chronic conditions, and improve efficiency. You should also consider the impact of the implementation to your practice. The first step in selecting any of these systems is to have a plan. Start by assembling a team to assess practice needs. Be sure to include key players from the revenue cycle such as patient service representatives, auxiliary personnel, providers, coders, billers, and finance staff. This will ensure that all aspects of the revenue cycle have input in making the correct decision to fit with your practice workflows. You will want to clarify your goals. Do you want a combined practice management system and electronic record? If not, will your current system integrate well with the system that you are looking to implement? What are you trying to accomplish? Write a proposal request which will allow prospective vendors to understand your practice needs, resources, and the priorities you desire in a practice management and/or electronic records system. Research and select the most appropriate vendor candidates and send out your request. Evaluate vendor responses and narrow the scope to those that meet your needs and ask for demonstrations. It is a good idea to create a rating form that includes the capabilities your team has deemed the most important for easy comparison of the vendors. Check at least 3 references for each vendor you are considering and ask to visit practices that currently use their software. Rank the vendors in functionality, cost, and customer service and make the best selection for your practice. Make sure the majority of your team is in agreement. Negotiate a contract to purchase and implement the system. Include timelines for implementation and ongoing technical support in your contract. An important part of your revenue cycle will be determining fees for the services, supplies, and drugs that your practice will deliver to patients. While there is not any limitation to what a practice must charge for a service, the methodology for determining fees is pretty standard across the industry. The same fee should be charged to every patient who receives the same service. Practices should not show favor to any patient, although discounts can be offered in certain instances as long as they are offered to everyone. A relative value unit, or RVU, is a weighting assigned to CPT codes, but not every CPT code has an RVU assigned to it. The total RVU assigned to a code is comprised of 3 separate RVUs, which are the practice expense, accounting for the practice's overhead costs, the malpractice portion, that accounts for the likelihood of complications, and a work RVU, which is the amount of work and effort the service takes. RVUs are part of RB-RVS, which stands for Resource-Based Relative Value Scale. The RB-RVS is effectively copyrighted by the AMA, but its use has been required by statute for Medicare claims payments since January 1, 1992. RVUs are updated yearly, but not every code will have a change from year to year. RVUs are used by organizations to determine fees for the services they render, so the RVUs should be reviewed yearly to determine if any updates to fee schedules are necessary. Fees for CPT codes are determined by multiplying the total RVU assigned to the code by a monetary conversion factor decided on by the practice. There is not a set monetary conversion factor, but the practice should evaluate fair market value for the geographical area that services are being rendered in. If the practice is in a heavily populated area, the cost of doing business will also be higher. So generally the conversion factor in metropolitan areas will be higher than a conversion factor used by practices in rural populations. Practices should review their payer contracts to make sure that what they are charging is not below the negotiated contract rate that the payer's fee schedule allows. If the practice is charging less than what the payer allows for a service, then the practice is not optimizing their revenue potential. The table on the right of this slide shows the 2016 total RVUs for established patient evaluation and management codes multiplied by a $60 conversion factor. This is for example purposes only and is not being recommended as the conversion factor for your practice. Generally, fees are rounded to the nearest dollar amount for bookkeeping purposes. Determining fees for supplies, drugs, durable medical equipment, and other codes that do not have a relative value unit assigned to them are determined by adding a markup to the practice's cost for that item or service. Payer contracts should be reviewed to determine what amount the fee schedule will reimburse a practice for each service or item that the practice will offer. The markup percentage should be set so that the final fee for the item or service exceeds what the payer will allow to optimize the practice's revenue. When a payer reimburses an item or service at 100% of what is billed, that is an indication that the fee for that item or service may be set too low. Understanding medical insurances will also be an important part of your revenue cycle. There are many insurance payers, and while there is some regulation in place, they all function slightly differently. Insurance contracting is important for managing your revenue cycle. While reviewing the contract prior to signing on the dotted line can be time-consuming, it's worth it to identify language or hidden agendas that you may want to eliminate. Many payer contracts have evergreen clauses that define deadlines for sending notice to discuss the contract's renewal. An evergreen clause automatically renews the contract for another term if the contract is not terminated within a specified notice period prior to the end of the current term. Look at the language pertaining to canceling your contract. If the contract does not allow for voluntary termination, ask for a 90-day out clause to be written into the contract so that if you find yourself in a bad contract where you are losing money, you can get out in 90 days without reason. Other language that you will want to verify in the contract are the guidelines used to process claims, timely filing limits for claims and corrected claims to make sure they are reasonable, which year's fee schedule will be used for claims payment, your appeal rights, and the requirements to bill a patient for a non-covered service. Negotiating with an insurance company is important to make sure it contains terms that are beneficial to your practice. Make sure to involve the right people from your practice, such as your office manager, coders, and billers. Ask for a yearly automatic cost of living adjustment and verify that your most used CPT and HCPCS codes are reimbursed at a fair rate. If not, ask for a fee schedule adjustment. If the contract does not allow for corrected claims to be submitted retroactively, ask that this provision be added to the contract as well. The payer may not agree to everything that you ask for, but negotiation should be part of your contracting process, and consider renegotiating your contracts annually. These are just a few of the many areas that should be reviewed in a payer's contract, and I recommend seeking the legal advice of a healthcare attorney. The year of the fee schedule used by a payer for claims payment determines the rate that the practice will be reimbursed. The table on this slide shows how RVUs can fluctuate between years. For E&M codes, the fluctuation can be minor due to changes in the work, practice expense, or malpractice RVU. This is why practices should try to negotiate which year's fee schedule will be used to determine their payer reimbursement. This table reflects the RVUs for office or outpatient E&M codes in 2011 and 2016. The codes in bold text indicate that there was a change in the RVU between these 2 years. The blue numbers indicate which portion of the total RVU was changed, and the numbers in red indicate the difference in the total RVU between these 2 years. So if a payer contract indicates that a provider will be reimbursed on a 2011 fee schedule, then the total RVU under the 2011 column is the weighting that the payer's conversion factor would be multiplied by to calculate the provider's payment. Some codes have a higher RVU weighting in 2011, while others had a lower weighting than 2016. Annual updates to the relative value units are based on recommendations from a committee involving the AMA and National Medical Specialty Societies, which is called the Relative Value Scale Update Committee, or the RUC. Credentialing is the process of establishing the qualifications of licensed professionals and assessing their background and legitimacy. Many healthcare institutions and provider networks conduct their own credentialing, generally through a credentialing specialist or electronic service, with review by a credentialing committee. Physicians and other healthcare practitioners who wish to bill an insurance company and receive reimbursement for their services as an in-network provider must undergo a process of credentialing in which the insurance company verifies the provider's education, training, experience, and competency. Each provider must submit a credentialing application that details their training and qualifications to treat patients in their area of specialty. The insurance company then decides if the provider meets their internal qualifications to serve as a provider of services to their insured customers. After approval of the provider's credentials, the insurance company issues a participating provider contract that allows the provider of services to bill the insurance company and receive reimbursement as an in-network provider. The process starts with completing the payer's credentialing form, which can be 20 to 40 pages long. Most insurers require a license, hospital affiliation, and malpractice insurance. Designate a person to be responsible for credentialing in your office and verify that credentialing forms are completed in full and all required documents are submitted with the original application. It usually takes months for a payer to complete the credentialing process, and if all required information is not included with the original submission, the process will take even longer, which can have a negative impact on your revenue cycle. Understanding the many various payment models for healthcare services will help your practice balance the budget. There are many different payment models in the industry, and they are always evolving, looking for ways to control costs while providing quality care for patients. I have listed some of the more common models on this slide, but there are many other payment models that are being tested in the industry. It is important to understand that any insurance company may offer many different payment models. Fee-for-service is the traditional method of reimbursement. Fee-for-service models have been blamed for skyrocketing healthcare costs because essentially the more services a provider or hospital delivers, the more money they stand to earn. The industry as a whole is trying to move away from fee-for-service payments and find ways to incentivize providers to control costs while providing quality care and improving patient outcomes. Managed care models limit the utilization of healthcare services and require patients to obtain referrals from their primary care physician or seek prior authorization for specialty care, even if the provider is in a payer's provider network. Bundled payment or episode of care models reimburse a provider a single negotiated rate for all services of a specified procedure or condition. These models base provider payment amounts on the costs of adhering to clinical standards of care, risk stratification, and complication allowances. They also incentivize provider performance based on a comprehensive scorecard. Under an episode of care payment system, providers automatically benefit from any savings they generate by improving efficiency within episodes and can also benefit from the savings they achieve by preventing unnecessary episodes of care. The payer saves money by paying a provider less money per episode or per patient than it has in the past. I strongly encourage you to research all of the payment options available in the market today for medical care to prepare your practice for the future. One HealthPort is a very useful tool for practices. A single sign-on offers healthcare professionals an easy and secure way to access the provider portals of major health plans as well as other valuable online services. Rather than placing time-consuming phone calls or repetitively logging into different websites with different passwords, One HealthPort users can access information from all participating organizations by signing in once with a single common digital ID. This protects and simplifies access and minimizes the risk of sharing information. One HealthPort is designated by Washington State as the lead organization for administrative simplification. One HealthPort offers a way to verify eligibility, check claim status, view payer policies, perform pre-authorization, credentialing, contracting, and other services for many payers. The definition of revenue cycle management in healthcare is the process of managing all aspects of the patient's encounter from pre-registration and scheduling to accounts receivable management and everything in between. This slide is a great representation of the revenue cycle from the beginning to the end. You will need to have policies, procedures, and workflows in place for each element of the revenue cycle to effectively manage your practice. Pre-registration happens over the phone when the patient calls to schedule their appointment. Have a script for your staff to follow to collect the patient's basic demographics, such as their name, address, phone number, employer, and insurance information. This will save time when the patient checks in for their appointment. Make sure to ask the patient if they have more than one insurance, and if so, obtain information for all payers. This will allow the practice to determine who is the primary carrier and enter the insurance information into the system. Coach your staff to ask the patient what problems they would like their provider to address. This will help select the appropriate appointment time so adequate time is allowed for the patient's issues. Most providers have a variety of appointment times on their calendars, and a patient with multiple problems will require more time than a patient with one problem coming in for follow-up. Also ask the patient to check in 15 minutes prior to their appointment, as this will give your registration staff time to complete the work they need to perform at the time of check-in so that the patient can be roomed and ready for the provider to see at their appointment time. Check insurance eligibility prior to the patient's appointment. If any prior authorization or referrals are required, make sure to obtain them prior to the patient's visit. Many insurance companies will not accept referrals or authorizations obtained retroactively. Set up any copay amounts in the system so that the money can be collected at the time of check-in. It is also good practice to remind the patient of their appointment a few days prior to give them the opportunity to cancel or reschedule the appointment if necessary, or to confirm that they are still able to make their appointment. Many systems now have the capability to set reminders to occur automatically. Train your front office staff who will be checking the patient in to verify the patient's demographic information and identification at the time of check-in. You will also want to obtain copies of the front and back of the patient's insurance cards. This information should be verified each time the patient comes to your practice for a visit. If a patient has changed their address or insurance company, it will slow down your revenue cycle if the information is not correct. If your practice will offer walk-in appointments for patients, all of this information should be collected prior to the patient being seen by the provider. Collect copay amounts at the time of check-in. Having the patient pay the copay at the time of their visit will save time and resources in your practice because you will not have to bill the patient for their portion after the insurance pays, which will save time and money on printing and mailing statements or dealing with collection issues if patients do not pay after receiving statements for their copays. Inform patients of their privacy rights under HIPAA and have them sign an acknowledgement that they received this notification. You will also want them to sign a general consent for treatment and obtain a signature allowing your practice to bill their insurance and have benefits assigned to the provider so that the insurance may pay the provider directly. Here is an example of a patient's medical insurance card. Each plan will have slightly different formatting, but the information contained on the card will be very similar. At the time of check-in, make sure that the information collected and entered into the system during pre-registration and scheduling is accurate and matches the information on the patient's card. By taking the time to verify this information up front, it will reduce the lag time it takes to receive payment from the patient's insurance. Number 1 indicates the policy or subscriber number. Number 2 indicates the group number. Number 3 indicates the copayments for office visits. Number 4 indicates the copay for an emergency room visit and urgent care visits, as well as their prescription copayment. Number 5 shows the payer's in-network benefits for the patient. And number 6 shows the out-of-network benefits available for the patient's plan. The back of the card will contain the insurance company's contact information and claim submission address. Auxiliary staff will room the patient, obtain and document the patient's vital signs, update medications, verify allergies, and the past medical family social history for the patient. They may also obtain and document the review of systems, which can save the provider time. Have a documented workflow for the duties they should perform so they know exactly what is expected of them during the rooming process. Everything in the workflow must be within the individual scope of practice. The provider will then have face-to-face time with the patient and review all of the information obtained during the rooming process to confirm or supplement that information. The provider will obtain and document the chief complaint, history of present illness, exam with findings, as well as their assessment and plan. A time statement may also be documented if the majority of the encounter was spent in counseling or coordination of care. The provider must also document any medications injected, tests performed, or supplies used during the encounter to support billing these services. Evaluation and management services are normally covered. However, if an injection or other service is going to be rendered, which has been determined to be a non-covered benefit by the patient's payer, the patient should be informed of the non-coverage and sign a waiver acknowledging that they will be financially liable for the cost of the service before the service is rendered. Not all payers require this, but if they do and the waiver process is not followed prior to the service being rendered, the payer may process the charge as a provider adjustment rather than patient responsibility. This is why it is so important to read the payer contract and check the patient's benefits prior to rendering services. Coding and charge capture can happen in a number of different ways depending on the capabilities of the system your practice has selected. If the electronic medical or health record has the capability for electronic charge capture, the provider can select the ICD-10 codes for the conditions addressed during the encounter and the CPT or HCPCS codes for the services they provided electronically. And depending on the system capabilities, this act may transfer the charges to the billing system. If the electronic medical or health record does not have this capability, or your practice has not yet implemented an electronic medical or health record, a paper fee ticket can be filled out by the provider for the patient's encounter. Generally, paper fee tickets will have all of the provider's most used CPT, HCPCS, and ICD-10 codes on a pre-printed form created by the office staff to make code selection easy for the provider. Another option is to route each medical record to a qualified coder to review the provider's documentation and assign the appropriate codes for the service and select the codes on a paper fee ticket. This is also an acceptable way to code the service, but the provider always bears the responsibility of any code submitted under their name and payer ID number. If electronic charge capture is not an option in your system, the codes assigned on the paper fee ticket will need to be manually entered into your billing system. This may be done by the same person assigning the codes or by another person who performs the charge entry. You will want to establish workflows for this process that fit the needs for your office and make sure to assign the appropriate resources necessary to generate a timely claim to the payer, as most payers do have timely filing limits for claim submission. Paper fee tickets should be batched by date and retained for your records. If your practice does not have the internal resources for billing, an external billing service may be hired to complete the billing process for you. The patient checks out at the designated area and schedules any follow-up appointments necessary or recommended. If the provider has referred the patient to other providers or for additional testing, make sure that the patient has the contact information for those other providers or testing facilities. If workflows allow, the staff responsible for checkout can assist the patient in getting appointments scheduled with the other providers or the testing facility. Once all of the codes for rendered services have been assigned, the claim form should be filled out completely with the information. If your practice is going to transmit the claim electronically, the form used is called an ANSI form. If a paper claim is going to be submitted, it will be a HCFA 1500 form. Claims submitted electronically will need to be submitted through a clearinghouse. A clearinghouse is a third-party organization that receives and reformats claims and then transmits them to payers. Some payers require claims to be submitted in very specific formats. Clearinghouses can ease the burden of medical billing by taking the information necessary to create a claim and then placing it in the appropriate format required for each payer. Scrubbing a claim means that it is reviewed prior to submission to make sure that it doesn't contain any mistakes that will cause a payer to deny the claim. Qualified staff should review the claim to ensure that there are no NCCI edits between CPT or HCPCS codes, and if NCCI edits do exist, modifiers should be appended to the CPT or HCPCS codes as appropriate to bypass the edits. Each CPT or HCPCS code should be linked to at least one ICD-10 code to support medical necessity for providing the service. The claim should also be scanned to make sure all relevant information is completed for claims processing. While claims may vary in their format, they typically have all of the same basic information. Each claim contains the patient's demographic and insurance information, the ICD-10, CPT, and HCPCS codes, along with the date of service and fees for each service. The claim form will also contain the provider's information, such as the payer identification number, address, tax ID number, and place of service code for the location where the service was rendered. Here is an example of a HCFA 1500 form. Instructions for completing this form can be found at the link provided on this slide. It will tell you exactly what information is required in each field of the form. Because the ANSI formatting for electronic billing can vary by payer, I am not able to provide you an example of that. However, all of the same information needed for a HCFA 1500 form will be required to complete the ANSI form for claim submission. When the payer receives the claim, it will be reviewed for eligibility on the date the service was rendered. The ICD-10, CPT, and HCPCS codes will be reviewed to make sure they are covered by the patient's plan, and the payer will either issue a payment or a denial. Under either circumstance, the payer will send the provider a remittance or explanation of benefits, also referred to as an EOB, explaining the payment or the denial. If payment is made, the appropriate payment should be applied to each charge in the provider's billing system, and if contractual adjustments or write-offs apply, those should also be deducted from the charge. If the patient has more than one insurance, additional payers should also be billed. A claim form containing all of the same information sent to the primary insurance will also need to be sent to the other payer, but the balance due would reflect what is still owing on the charge. The claim form will need to be accompanied by a copy of the primary payer's explanation of benefits. Once all insurance plans have been billed and payments received, if a patient balance exists, generate and mail a statement of the balance due to the patient. Here is one example of a payer's explanation of benefits. Each insurance company will have its own format, but like claims, they will contain the same basic information. When a batch of claims for your practice is processed under the same check run, many patients' explanation of benefits may be contained in the same document. Each patient's charges will be listed, showing the final processing for each service. I recommend batching your EOBs from all payers by the date payments were posted to your billing system, or some other organized filing method to retain these important documents so they can easily be retrieved. On this EOB, we can see the date of service, the CPT code, and the number of units billed. The charge was $650. The payer allowed $354.82. The non-allowed amount was $295.18 with a message code of 01, which states the amount was in excess of the allowed expense for a non-participating provider. No deductible applied to this claim, and the patient's coinsurance is $141.93. The insurance payment made to the provider was $212.89. Because the message code for the non-allowed amount is for a non-participating provider having charges that exceeded the payer's allowable amount, this may be billable to the patient. If the provider participated in the network, The amount over the payer's allowable would be a contractual write-off. Many payers now offer providers electronic data and fund transfers instead of paper EOBs and checks. In these cases, the payment will be directed to an account you have specified, and you will receive an electronic version of the EOB. Review your denials to determine why a claim was not paid. If the denial reasons are due to coding, review the medical record to make sure coding is correct and modifiers were appropriately applied. If claim scrubbing is performed pre-submission, this should not be the issue, but it is always good to double check. If the coding is inaccurate, correct the coding and resubmit a corrected claim to the payer. If the claim is denied again and it has been determined that the coding is correct and the service should be a covered benefit under the patient's plan, appeal the denial with chart notes supporting the services and follow the payer's appeal process. If the claim is denied due to provider credentialing issues, follow up with credentialing to see what the issue is. This could very well be a payer error if the credentialing was completed prior to the service being performed. If for any reason the charge in full is listed as a provider adjustment on the EOB, make sure to investigate why and explore all possibilities to get the claim paid prior to writing the service off. If copayments were collected at the time of check-in, any copay amount showing on the EOB should already be posted to the billing system. Charges that are applied to the patient's deductible or coinsurance amounts will need to be balance billed to the patient after all of the patient's insurance carriers have been billed. Make sure you do not bill the patient for any contractual adjustments. If the claim is denied as patient responsibility due to eligibility issues or incorrect patient information, bill the patient. If the information on file is inaccurate, the patient can contact your office to provide the correct information and the claim can be resubmitted. Provide the patient with itemized bills and medical records if requested. To optimize your revenue, routine audits of payer payments and adjustments should be conducted to make sure that the practice is being reimbursed at the contractual rate and that the adjustments do not exceed what the provider agreed to. If errors in payment or adjustments are identified, contact your payer representative to determine the steps needed to correct the issue in the payer system and also to recoup any additional payments that are due to the practice. If this process is not in place, the practice may very well lose out on money that is owed to them by the payer. As discussed throughout this session, policies and procedures in your practice will help to optimize your revenue by standardizing how things are done. Implement streamlined clinic workflows that will ensure the patient is roomed and seen by the provider in a timely manner. Educate providers in coding and good documentation practices so charges are supported in the medical record and any payments received can be retained. Educate clinical staff in appropriate billing and documentation to support services performed under the Incident to rule so that all requirements are met. Keep charge capture processes simple and educate providers in the process and how important it is so they understand their role in getting a timely bill to the payer. Make sure clinic staff and providers have adequate training about the system's functionality so that encounter notes and orders are filed appropriately and can be easily retrieved for review. Implement workflows for every area of the revenue cycle on the administrative side as well. Make sure employees understand all of your practice's policies and procedures and monitor them to make sure they are following the appropriate workflows. If an employee is missing a step, it can throw off your entire revenue cycle and potentially impact your practice financially. It is always a good idea to cross-train staff, so if someone is away on leave or decides to leave their position, another employee can take over and the work will not fall behind. Any forms that are used by a practice should be standardized, whether they are in paper or electronic format. Health history forms may or may not be used by a practice to gather patient demographic information and medical history. It should be completed by the patient prior to their first appointment. It can be given to the patient at check-in, mailed to them, or filled out online if the practice has that capability. The practice should decide what information is included on the form, but generally it will ask for information pertaining to the patient's prior health and symptoms, current medications, social habits, and family history. Consent to treat forms give the provider permission to treat the patient. State laws should be followed regarding consent, and while a general consent is required for E&M services, more specific consents may be required for other treatments or procedures. General consent is usually presented to the patient at check-in, but more formal consents should be presented by clinical personnel for full disclosure of risks associated with the treatment. Even if the provider does not personally go over the consent with the patient, they bear the responsibility of making sure it is done correctly. The patient and provider should sign the consent for specific treatments prior to the service being rendered. Whether your office is using a paper fee ticket or an electronic charge capture list, make sure it contains all of the provider's most used CPT, HCPCS, and ICD-10 codes, and that they are in an organized format that the provider understands. Get provider feedback on the structure of the charge capture method before implementation, and update yearly to add new codes for services the provider will perform and remove codes that have been deleted. Waivers for financial responsibility are forms presented to the patient prior to the service being rendered. They are used when treatment may not be covered by the payer. Many payers have their own policy about billing patients, and your contract should be reviewed for specifics. For example, if the payer has a medical policy for a service, but the patient's condition does not meet the payer's specific criteria, some payers will require that the patient be notified prior to the service being rendered, informing them of their financial responsibility. Medicare has its own waiver called an Advanced Beneficiary Notice, or ABN, and Washington State Medicaid also uses a specific form that can be found on their website. Commercial payers don't usually have their own waiver forms. However, the practice should have a standardized form for all other payers stating what service is being rendered, the cost, the reason for possible non-coverage, and a statement that the patient is agreeing to assume financial responsibility for the service. It is always a good idea to inform the patient up front, regardless of payer requirements, so there are no surprises after the fact, or the patient may be very upset. Having standardized policies for billing and discounts is an important step in remaining compliant. All patients should be treated fairly, and the amount charged for a service should be the same for all patients who received that service. While fee schedules can be updated, the updated fees should then apply to everyone. It is acceptable to charge a fee for no-show appointments, but patients should be made aware of this policy prior to sending them a bill. Discount policies such as prompt pay discounts may also be appropriate in certain cases. These policies should be written and distributed to all employees to make them aware of the practice's policy. I would recommend seeking legal advice regarding any of these types of policies and any required signage that may need to be posted prior to implementation. Implementing a compliance plan is an important step to making sure that your practice will be protected from accusations of fraud, waste, and abuse. Designate a compliance officer to develop the plan and monitor for compliance issues. Educate everyone in your practice about the plan and the definitions for fraud, waste, and abuse. Compliance plans only work when everyone participates, so encourage employees to report their concerns and have an easy way to report them. Make sure to investigate all concerns reported and follow through with any corrective action to ensure the compliance concern is eliminated. An auditing policy will ensure that billing is being performed correctly and compliantly, and that the practice's internal policies and procedures are being followed. Monitoring a provider's code utilization for outliers against the national average will identify potential problem areas and allow your practice to make corrections. By performing internal quality assurance audits, the practice reduces their risk if an external audit is performed. Here are the sources for this presentation. Please review them for yourselves for further understanding so that you may plan appropriately for the needs of your practice. Thank you for listening to this session. I hope that it has helped you to understand the medical revenue cycle, and you will be able to develop policies and procedures that will optimize your practice's revenue.